Am I audible to you? Eknath, am I audible to you?
Yes, sir. Yes, sir.
Okay.
Good evening, sir.
Good evening. Good evening. We'll wait for 5 more minutes. Only
Yes,
1, 2, 3. Only 4 people have logged in. We'll wait for about 5 minutes before we start the program. So we came. Did we discuss the clinical findings last time?
Yeah, we discuss auscultation after auscultation, sir. We reach to the final diagnosis, means to discuss final diagnosis.
Did we discuss the interpretation of each murmur?
Yes, yes, we have discussed that, sir.
Okay, now and then we have to come to a diagnosis, and then we'll go to the investigations.
Sir, whenever you want to start, just ask me. I will give you the countdown, and after that, I will start the recording, sir.
Not yet now, because let us see whether few more students can join, and then we can start in another 5 to 10 minutes.
Okay, sir, sure.
Okay, Eknath, shall we start?
Sir, yes. After my countdown, you can start, sir.
Right. Prayag, you can do the countdown and then initiate the.
Yeah. So it's 3, 2, 1. Over to you, sir.
Thank you. Okay. Eknath, you can start the discussion. Just to recapitulate, we have got 5 murmurs. Just give me your interpretation of these 5 murmurs.
So first, that pants started blowing high-pitched murmur, best audible at apex, conducted to the axilla, better audible in the left lateral position. No change with the breathing grade. It's a breathing grade 3/6. It's a mitral regurgitation murmur, sir.
Very good. Okay.
Then early systolic blowing high-pitched murmur, audible in fourth and fifth intercostal space, close to the sternum. Increase on inspiration and passive leg raising, grade 2/6. It's a tricuspid regurgitation murmur, sir.
What happens when you are doing the leg raising?
Sir, it's a preload. So venous load return is increased, and preload is increased.
How much venous return increases? What is the increase in the quantity of the venous return? It is estimated that by both leg raising, in sometimes the increase in the venous return over a period, maybe about 5 to 10 seconds, can be as much as 300 ml. Such a large volume of blood can be returned to by raising both the lower limbs over a period of 10 to 15 seconds. Okay, right. So it is how will you differentiate the left-sided murmurs from the right-sided murmurs by passive leg raising?
Sir, right-sided leg murmurs they are increased due to increasing preload.
Left-sided murmurs?
There is no change in murmur.
No, that's not correct. Anybody who would like to modify it?
Right-sided murmur, sir, increases with the inspiration, sir. And left-sided decreases, sir. It is called Carvalho sign, sir. Right-sided murmur increase with leg raising called Carvalho sign, sir.
Okay. See, the right-sided murmurs increase within 1 to 2 beats, and the left-sided murmur may remain the same or may decrease. And the left-sided murmurs can increase up to 5 to 6 beats. So just a minute. Hello? ആരത് ജോബിന മറ്റേ ജോഫിൻ അപ്പൊ മുമ്പ് വന്ന രണ്ടുപേരില്ല അതിനകത്ത് ഓ ഇവനെങ്ങനെ തിരിച്ചറിയാൻ അവന്റെ ലൈസൻസും എല്ലാം കൊണ്ടുവരാൻ പറയണം അതെ മതി ഏഴേകാല ഇത്തിരി മുമ്പ് വരണം 7:20 ആകുമ്പോഴത്തേക്കോട്ടെ ജോഫിൻ അല്ല മുമ്പ് വന്ന രണ്ടുപേരിൽ ഒരാളുണ്ടായിരുന്നെങ്കിൽ സൗകര്യമായിരുന്നല്ലോ അവന്മാരില്ലേ ഓ ശരി രണ്ടുപേരും ശരി 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 ആ ലൈസൻസും കൂടെ കൈകൊണ്ടിരിക്കാൻ പറയണം ശരി ജോഫിൻ അല്ലേ ശരി അല്ല അവൻ ഓടിച്ച് പരിചയമുള്ള പാർട്ടിയാണോ Okay, so the right-sided murmurs increase within 2 to 3 beats of raising the leg, and the left-sided murmurs can increase after 7 to 8 beats when the increased ejection from the right ventricle can reach the left ventricle. So initial increase is always associated with right-sided murmurs. Later increase is associated with left-sided murmurs. Here it is no mention about after how many beats it increase, but it seems that it must be happening immediately following the passive leg raising, and so it is the right-sided murmur. Okay, very good. Yes, third murmur.
Then mid-systolic rough and harsh medium to high pitch, early picking, ejection systolic murmur in right intercostal space close to the sternum, better audible in setting up and in leaning forward with breath held in expiration conducted to the both carotid, group 3/6. Murmur, that is the
murmur is audible in the
so murmur audible in left intercostal space, sir. It's that is the ejection, that is systolic murmur due to the dilatation of the aorta due to the turbulence.
Okay. So it can be due to two reasons. One may be due to why did you say there is a dilated aorta?
So aortic root dilatation.
How do you know? How are you sure?
Sir, actually, it is in.
So it is a flow murmur for the aortic, relative aortic stenosis.
Yeah, that would be the first explanation, because in a patient with aortic regurgitation, what happens to stroke volume?
Stroke volume is increased.
Stroke volume increased. When there is a large stroke volume is ejected through a normal valve, it can create a turbulence, and they can have a ejection systolic murmur. And what will be the peaking of the ejection systolic murmur? produced because of the increased flow across the normal valve? When will it peak?
Early peaking is there.
Early peaking. The murmur will peak early. If there is a severe aortic stenosis, which is giving rise to the murmur, it will be a late peaking murmur. So here this is an early peaking murmur, and all the features are suggestive of the increased flow across a normal valve. So it is because of the aortic regurgitation, stroke volume increases, turbulence is produced across the normal aortic valve. Okay, right. Fourth one.
Fourth one is early diastolic blowing high-pitched murmur, best audible in second right intercostal space, heard down along the left and right sternal border. It's more on left than the right. Better audible with the patient sitting and leaning forward with the breath head in expansion 2/6. So it is an aortic regurgitation murmur, sir.
Very good. And what is your interpretation about the second right intercostal space? The murmur is best audible, heard along the right and left sternal borders.
Sir, if we get a murmur on the left third intercostal space or second intercostal space, it is due to the valvular lesions, sir.
Okay.
And if we get murmur on the right side, it's mostly due to the annulus, annular dilatation.
Okay, it is due to as a whole aortic and annular dilatation.
Right.
So what is your interpretation in this patient?
Sir, in this patient, sir, left side is more than the right side, sir.
Okay.
So it's a valvular lesions.
Okay, but then the murmur is audible on the right side also very well.
But it's more on left side, sir.
Okay, why can't you say that it is a combination both valvular as well as vascular pathology?
So it is probably associated with the dilated aortic root.
Yeah, you can interpret both ways. You can say that probably the patient may be having a dilated aortic root, and that is why the murmur is audible on the right side. At the same time, the murmur is better audible on the left side and down along the left sternal border. It is audible on both sides. So a possibility of both aortic dilatation as well as a valve pathology can be considered. What can be the condition where there can be valve pathology as well as an aortic dilatation?
Sir, in valve pathology, there's a rheumatic heart disease, sir.
The Marfan's.
Then
there can be a
then calcified walls.
No, I'm not asking a question. No, I'm not asking what is the causes. I'm asking a question. What can be the situation where you can get a aortic dilatation?
Sir, Marfan.
Sir, we get Marfan syndrome. Then Ehlers-Danlos syndrome, sir.
Okay. No, I'm asking associated aortic valve pathology also. Marfan syndrome, there can be annular dilatation, but aortic valve can be normal.
Sir, bicuspid aortic valve.
Yes, very good. Bicuspid aortic valve. Bicuspid aortic valve may be associated with what?
Sir, aortopathy.
Aortopathy. It may be associated with aortopathy. It is thought to be due to a genetically transmitted weakness of the aorta, which is resulting in dilatation of the aorta, and also thought that the eccentric jet of the bicuspid aortic valve impinging on the aorta, starting from the intrauterine life, can weaken the aorta, and that can result in aortopathy. So whenever there is a situation where both sides murmurs are well audible, you can always think whether it could be a bicuspid aortic valve, and along with that there is an aortopathy also.
Sir, is syphilitic AR possibility in this scenario?
Yeah, I think we have to definitely consider that also, because Leutig involvement also should be considered, but then you cannot explain mitral regurgitation.
No, so just the aortic, if we are expecting as a differential, can we give syphilitic?
Yes. Then you have to explain, saying that probably the LV dilatation might have resulted in mitral annular dilatation, mitral regurgitation. You can definitely, that also forms part of the differential diagnosis, etiology. We have to discuss the etiology also. Okay, right now the fifth murmur, a low-pitched mid-diastolic rumbling murmur. What is it? What is the interpretation?
It's Austin Flint murmur.
Why did you say that it's Austin Flint?
Because sir, it's a low pitch and mid-diastolic.
Sir, it is a flow murmur across the mitral valve, sir. It's a flow murmur due to mitral regurgitation. There is overloading of the LA, and that is a flow murmur across the mitral valve.
So you are suspecting that the mitral regurgitation is severe?
Yes, sir. Yes, sir. It's a pansystolic. The first also murmur is pansystolic murmur. So probably dilated LV due to the volume overload, and that is a cause of annular dilatation causing severe MR.
Okay. Tell me the situations where you can get a mid-diastolic rumble at apex. 5 or 6 situations. Mid-diastolic rumble at apex.
VSD, PDA.
VSD, PDA and
MR.
Oh, this due to increased flow across the mitral. Okay, right.
Yes.
One mechanism. Another mechanism. Causes of mid-diastolic rumble at apex.
Sir, MS.
Mitral stenosis, very good. Yes.
Sir, Austin-Flint murmur.
Austin-Flint murmur, yes, very good.
Sir, sometimes, sir, in ASD, if very much enlarged, then sir, the RV is enlarged, then we can hear the TV tricuspid valve murmur at the apex.
Very good. In a IST where the apex is formed by the right ventricle, the tricuspid flow rumble can be heard at the apex and may be mistaken for a mitral murmur even. So very good, excellent. Yes. What else?
And then, sir, Austin-Flint murmur.
Austin-Flint murmur, very good. Few more. At least 3 more.
LA myxoma.
LA myxoma, very good. Excellent. Very good. 2 more.
Ball thrombus.
LA ball thrombus usually occurs in mitral stenosis. So already there is a murmur because of mitral stenosis. 2 more. Carico's murmur.
Yes, sir.
And core triatriatum. So these are the few conditions where you can get a mid-diastolic rumble. Now you have to choose what is the cause of this mid-diastolic. Is this mitral stenosis? Agnath, is it mitral stenosis?
It's not looking nice.
Why?
It looks like Austin-Flint murmur.
Austin-Flint.
Why did you say that? How will you differentiate Austin-Flint murmur from mitral stenosis murmur?
Sir, in mitral stenosis murmur, sir, S1 is loud, sir.
Okay. Here S1 is feeble. Very good. Yes, feeble.
Second is there is the opening snap is present, sir.
Very good. Excellent. That is not audible here.
Then a presystolic accentuation is there, sir.
Very good. Excellent.
Yes, sir. In case of mitral stenosis, RV get dilated, sir. Right ventricle.
So that depends whether the patient has developed pulmonary artery hypertension. Okay. Yes.
Then in case of this aortic Austin-Flint murmur, due to the aortic regurgitation, LV get dilated, sir.
Okay, he already has got LV dilated, LV apex, but we are still suspecting whether this
and abile nitrate decreases the Austin-Flint murmur. Yeah, and,
okay. Two other simple things that you can mention is that if there is a thrill associated with murmur, that goes more in favor of mitral stenosis. Okay. And if the patient is having complications which are referable to mitral stenosis like atrial fibrillation or pulmonary arterial hypertension, that also favor mitral stenosis. So you can always think of five points to differentiate Austin-Flint from mitral stenosis. 1, S1 loud, mitral stenosis. Presystolic accentuation, mitral stenosis. The opening snap, mitral stenosis. The presence of a thrill, mitral stenosis. Complications like atrial fibrillation and pulmonary arterial hypertension favor mitral stenosis. So, is this patient having any of these?
No, sir.
Oh. Then now there is a second question. Say one of our students have said that this is due to an increased flow across the mitral valve. How will you differentiate?
Sir,
the increased flow through the mitral valve will give the S3 before Austin-Flint murmur.
Very good, excellent. The absence of S3 in this patient goes against the diagnosis of an increased flow across the mitral valve. If there is an increased flow across the mitral valve, that will give rise to a third heart sound. In a patient with aortic regurgitation, can you get a third heart sound?
No, sir.
But you can get it when
acute AR, sir.
Acute AR
will give rise to S4.
Who said that point? Acute AR can give rise to S4? Who said that?
Sir, Monica here, sir.
Monica, that's not correct. Because S4, acute AR is one condition where there will not be any S4. Can you give the reason?
But LVEDP will be very high, sir.
Yes, so?
So I thought because LVP will be very high, diastolic dysfunction and diastolic dysfunction will set in and will give rise to S4. That's what I am thinking.
No, that's not correct. Now, anybody who would like to give an explanation? I'm saying that in acute AR, there will not be an S4. There are 3 conditions where you will not get an S4. They are: 1, can you tell me 3 conditions where you will not get S4?
Atrial fibrillation.
Atrial fibrillation.
Constrictive pericarditis.
So whereas you can get a,
You can
not
get
usual, you know, not usual, but you can get mitral stenosis and
acute
okay,
severe.
you think,
Acute severe. Yeah.
Just a minute, you have to wait for 5 minutes. My car, which is given for servicing, has come back. So just 5 minutes. I have to, just 5 minutes.
Why acute AR then?
It is written that LV feeding pressure becomes elevated and the early diastolic pressure of LV rises. So that results in premature closure of mitral valve, which causes there is no S4. That's why he's asking.
Sorry, sir, but Dr. Rajan is not there.
No, I was trying to interact with others, not with sir. I know sir is not there.
That could be the reason, but I still feel I read somewhere during
No,
my
it is
exam.
written that S4 could be there, sir, madam. But what just now I read only after sir has told that there will be increase in early to mid LV diastolic pressure suddenly, which will cause premature closure of the mitral valve. So there will be no S4 and presystolic component of first infant murmur will also be not be there.
No, that is correct. And that is correct. That is a part of Austin Flint, sir.
But
But,
S4 also present, they have written S4 may be present. But
that way we can say that is functional MS, sir. Okay, fine.
Yes.
That way he is saying, but usually I guess it should be present because of very high EDP. Because not
That
all acute
yes,
severe
ma'am.
MR, not all acute severe AR may impinge into my AML.
No, madam.
Getting
It is not about impinging. They said that because of that increased LV filling pressure, there is
early
this
closure
rise has
of,
caused premature closure of
Premature
mitral valve. Yes.
closure. Okay,
Uh,
okay. Where did you read this?
This is given in Jonathan, madam.
Okay. Abrams, sir.
Yes, ma'am.
I'll just check. I have the book with me. Good, you told me. Because
Thank you.
I was thinking in pressure terminologies.
Yes.
Good.
Even
Okay.
your after your review only, actually, I again read it. Thank you.
No problem. I thought it this way. How it
Ah,
happens in aortic stenosis, no?
yes,
That
ma'am. Yes.
same way. I thought because of raised LVDP. But good. I'll just check in Abrams. After exam, books are kept. In S4 chapter, no?
No, I mean AR only. In AR chapter, acute AR only there.
Okay. I'll just check. Thanks. Can you tell me the page number? Because here
270, ma'am. 270, ma'am.
I'm seeing the aortic regurgitation chapter.
Nice, ma'am. That only it is given. 270 page.
Maybe mine is old version.
You're having a synopsis or illustrative only.
Sorry?
There are two books actually. One is I think synopsis or something. One is somewhat.
Essentials of cardiac physical exam.
Yes, ma'am. In that it is 275.
270. I am reading 257 in
Yes.
aortic regurgitation. Okay. So
Yes,
fourth
ma'am.
ultrasound, what it is given is? Hello, can you hear me? Till sir
Yes,
comes, we
yes,
can
ma'am.
discuss.
Yes,
While
ma'am.
an atrial sound is uncommon finding in mild aortic regurgitation, It may occasionally found in a moderate aortic incompetence in common severe disease.
Yes, ma'am.
Okay. Long
Yes,
PR interval common in many patients with aortic regurgitation, increases audibility of an S4. An
Yes,
S4
ma'am.
suggests increased left ventricular stiffness and elevated LVEDP. The
Yes,
S4
ma'am.
may be manifest at apex as palpable presystolic distension when the patient is turned on the left side. In some
Yes, ma'am.
persons, the S4 of such low frequency and intensity as to be inaudible, although it is readily palpated. Now, where it is yours given?
This is 258, ma'am. Just turn I think 4 more pages, 5 more pages.
Now it is whatever I said also correct.
Yes, ma'am.
Correct. 270 is.
Which book is this?
This is Abrams, Jonathan Abrams.
Okay, right.
And wait a minute, I'll just see.
Just where there is given heading as acute aortic regurgitation, ma'am. Under
I'll
that heading.
read. 270. Okay. S1 is soft and there is no S4 or presystolic component of Austin-Flint's murmur in
Before
acute AR.
Before that only that line which I told you.
Yeah, but there are two in contradictory statements.
Yes, yes, that's why we discussed good.
We should discuss because correct, because there is no effective atrial contraction because of premature closure. So ऐसे पूछेंगे.
Okay.
No, but what he's saying here also, and maybe it is chronic AR. Let me see. It is acute chronic.
Especially, he has not mentioned their acute or chronic actually, where he has mentioned moderate.
I think it may be
Okay.
audible in. Sorry.
Okay.
Hello.
So where were we? Okay.
Sir, we were at why there
situations
is no S4.
where there will not be S4. Okay. Yes.
So
One
why
is,
there is no S4 in acute severe AR?
Okay.
That's right.
The S4 is usually not audible, of course, in atrial fibrillation. And another is mitral stenosis. You will not hear a S4 in mitral stenosis. And also, you will not be able to hear in acute AR. Can anybody give an explanation why in acute AR S4 is very unlikely?
Sir, we just read. Actually, somebody we were discussing when we were not there. We read in Jonathan Abrams. Two different things are there, but you can tell. I think
you tell me whatever you read, then I will explain it.
Okay, sir. According to Jonathan Abrams, they say because there is premature closure of the mitral valve.
Yeah, that's
and the LV pressure rises in early and mid diastole, and premature closure of mitral valve. So the S4 is not produced.
Yes.
That is what he told me.
That is the main explanation, that during acute AR, the AR is coming into a ventricle which is not prepared. So when
there is
there is a when the ventricle is not ready to accept a sudden surge of volume, that will give us an acute rise in the LV diastolic pressure, and that will quickly go above that of the left atrial pressure, and there will be a diastolic closure of the mitral valve, and even there can have a diastolic mitral regurgitation. And the left atrial pressure at that time may not be sufficient enough to open the mitral valve, and then and because of that you cannot get an S4 even at the time of atrial contraction. So that is the explanation why there cannot be an S4 in a patient with real acute AR. There won't be an S4, but in a patient with acute AR, sometimes there is a nature's compensation that sometimes there can be prolonged PR interval. Yes, and when there is a prolonged PR interval, sometimes you may be able to hear S4 because of the prolonged PR interval. But in a patient with acute AR, if the PR is normal, you will not hear a fourth also. It is because of the acute rise in the left ventricular diastolic pressure, where the LV is not prepared to receive the large volume acutely, and the LV pressure can go very high. It may go to 40 or 50, and the premature closure of the aortic valve is a protective phenomenon. Premature closure of the mitral valve is a protective phenomenon. Why?
Prevent the acute pulmonary edema due to high pulmonary venous pressure that is transmitted.
Very good. Because of the left because of the closure of the premature closure of the mitral valve, the LV diastolic pressure, which is very high, cannot be transmitted to the left atrium. And because of that, the patient can be saved from development of acute pulmonary edema. They can develop very slightly later, but acute pulmonary edema can be to some extent arrested or can be brought down because of the closure of the mitral valve, because of which the acutely elevated left ventricular diastolic pressure is not transmitted to the left atrium. Okay, what is the next point that Abrahams have written?
Which one, sir?
This, sir, actually two explains already too. Firstly, for the acute AR, and the second expression actually mostly due to the chronic AR, sir, actually.
Oh, chronic AR, when there is a third heart sound, what is the interpretation?
LV dysfunction.
LV dysfunction. Whenever there is a third heart sound in a patient with aortic regurgitation, unlike in mitral regurgitation, you should suspect that the patient may be having a left ventricular dysfunction. If somebody is to have both, if you have a choice to have mitral regurgitation or aortic regurgitation, what will you choose, Agnath? Suppose you have got a choice.
Sorry, I didn't.
Suppose you have got a choice to choose between aortic regurgitation and mitral regurgitation. What can the patient choose? Of these two lesions, which can give rise to more symptoms, more complications?
MR.
Give the explanation. Give explanation.
Sir, actually, MR after a long time it leads to the increased causes pulmonary increased LA dilatation that lead to the pulmonary congestion, and after that the pulmonary hypertension.
Afterload mismatch.
Patient with mitral
regurgitation will have acute MR, acute pulmonary edema due to direct transmission of pressure into the pulmonary bed.
Yeah. The mitral regurgitation can give rise to two important complications. One is development of atrial fibrillation, and other is the patients can develop pulmonary arterial hypertension, especially if the left atrium is slightly less compliant, and also if there is a jet directly going into the pulmonary veins, the pressure can be directly transmitted, and that can give rise to pulmonary venous congestion. The patients can go for pulmonary congestion, pulmonary edema, and also they can have atrial fibrillation. Okay, that's one point. Second point?
Atrial fibrillation.
Atrial fibrillation, that we have already mentioned. pH and
one more is afterload mismatch also, sir.
Okay, what is the afterload mismatch here?
So in case of mitral regurgitation, the LV is regurgitating the blood in a low chamber pressure. As a result, but in case of aortic regurgitation, it is not like that.
Okay.
So
what?
Sir, so post-operatively or sir?
No, that's right. That is only when you are operating. I agree with you. Whenever there is an operation, when the aortic mitral valve is replaced, these patients can have afterload.
Mismatch in case of mitral regurgitation.
What do you mean by afterload mismatch?
So it means that LV will not be able to cope up with the when we have done the mitral regurgitation operation. Now it has to face the higher pressure in aorta.
That is right, but you have to define what is meant by afterload mismatch.
Yes, sir.
What do you mean by afterload mismatch? And can you give me one or two examples of afterload mismatch? Any one of you?
Afterload, mismatch is left ventricle is unable to
basically inability of the left ventricle to contract effectively due to the
either ventricular pathology
lack of adequate preload.
Sudden rise in afterload.
See, afterload mismatch is that situation where a sudden change in the afterload, where all other conditions remaining, contraction, contractility, everything remaining the same, LV is not able to compensate. So everything should remain the same, contractility, everything remaining the same. When there is a sudden change in the afterload, the LV is not able to compensate. The best compensation for what is
hypertensive heart failure also, sir.
Very good. Acute rise in pressure. When there is acute rise in pressure, there is an acute afterload mismatch. The patient develops pulmonary edema.
So like in renal flush pulmonary edema.
Yes. And as you rightly pointed out, in a patient who has undergone a mitral replacement, there can be afterload mismatch. So you should be very clear what is meant by afterload mismatch. Afterload mismatch is a situation where an acute change in the afterload, where all other parameters remaining the same, patients develop acute LVF. So when you handle the sudden change in the afterload, patient can get back to normalcy. For example, a patient with sudden acute hypertensive crisis, you control the blood pressure, patient can quickly get back to normalcy. So afterload mismatch is that situation where an acute change in the afterload, with other hemodynamic parameters remaining the same, patient develops the ventricle fails because it is not able to handle the acute change in the afterload. That is known as the afterload mismatch.
It is the decreased contractility due to the increased in afterload due to any reason.
Yeah, increased afterload. What is the compensation for increased afterload? Normal compensation.
Because of increased
concentric elevation, increased hypertrophy. Increased hypertrophy.
No. When there is a sudden change in the afterload, you cannot go for hypertrophy and all. So what is the hemodynamic compensation?
So first initial stage it will be afterload. Increased contractility, tachycardia, increased contractility, and then once it is continued.
But what is the stimulus for increased contractility? What do you mean by increase in the contractility? What are the situations where there can be increase in contractility?
Frank start.
Sir, exercise or emotional stress?
No. Yeah, emotional stress. What are the things which actually cause increase in contractility?
Physiological physiological condition, pathological condition. In case of cardiogenic shock.
No. You don't have to say all those things. Contractility is controlled by. How can you increase the contractility of the ventricle?
Preload, increased preload.
Increase overload.
Preload, basically preload. Frank Starling's law.
Oh, again wrong. Does the preload again?
Preload is correct. No, sir.
No. Does the preload increase contractility? Define contractility. I think you have to be very clear. There is a lot of confusion. Your understanding is not correct. What do you mean by contractility? Define it, then it will be clear to you. Any one of you, can you define contractility? Contractility is defined as the intrinsic property of the myocardium to contract independent of the loading conditions. It is independent. It is independent of preload and afterload. It is the intrinsic property of the myocardium. You are confusing between force of contraction and contractility. These are two terms, entirely different terms. What are the conditions in which you can increase the force of contraction?
Inotrope, sir.
Inotrope. That is a contractility. Inotropes increase the contractility. Inotropes increase in contractility. 2. How can you increase the force of contraction of the ventricle?
Sir, exercise.
No, exercise has got multiple mechanisms, but you have to say what happens in the heart.
Increase preload.
Preload, increase in the preload. Right. Increase in contractility, increase in preload, and third one?
Increase the heart rate, sir.
Increase in heart rate. Tripping phenomenon. These are the three things which increase the force of contraction. Increase in the preload, increase in contractility, increase in the heart rate. Contractility is the intrinsic property of the myocardium to contract. It has nothing to do with preload. Okay. It's very clear. And contractility is defined as the intrinsic property of the myocardium to contract independent of the loading condition. Preload as well as afterload. So don't go when somebody asks you how can you increase the contractility, don't answer that by increasing the preload. You can increase the force of contraction, but not contractility. Okay. So where did we? Okay, we went to this. So my question.
So how can we actually increase the contractility, sir?
Why
Inotropes increasing heart rate.
Deoxygen will increase. It is inotropes, catecholamines can increase the contractility. Then digoxin can, any drug which can increase the inotropic effect can cause increase in contractility. These are the drugs which can cause contract. And when you exercise, there is a catecholamine release, contractility increases. The body has got a defense mechanism by which it can increase the cardiac output. What are the mechanisms by which heart can increase the cardiac output? 4 mechanisms. How can the heart? See, normal cardiac output is only 5 liters per minute. What is the maximum cardiac output possible in athletes per minute? Any one of you? What is the maximum cardiac output which is possible in a good athlete? Up to 30 liters. It can go up to 30 liters per minute. It can actually increase by 6-fold. Actually, if you look at every organ in our body, the reserve of the body, the organ is almost 6-fold. If for the resting state where there is no stress, only 1/6 of the organ is enough for normal resting performance. Normally, when we don't exercise our brain too much, we use only about 15% of our brain. When you look at kidneys, we need only 1/3 of one kidney. So all about 1/6. The heart is also same. Usually 1/6 of the heart is enough to maintain resting cardiac output. But when you exercise, we want great demand, we can increase up to 30 liters per minute. So I'm asking a question, what are the mechanisms by which you can increase your cardiac output? These are known as cardiac reserves. You make use of the cardiac reserves. And tell me, what are the cardiac reserves?
Sir, increase the rate.
Increase heart rate, very good. Increase in heart rate. 1, 2. 3 things increase, one in decrease. Increase in heart rate.
Increase in preload.
Increase in preload, very good.
And decrease in afterload.
Decrease in afterload. And increase in? We just discussed about it.
Force of contraction.
Not force of contraction, contractility.
Contractility.
All these things increase the force of contraction. But contractility. So 4 things are the cardiac reserves. Preload, contractility, afterload, and heart rate. So by increasing the preload, increasing the contractility, increasing the heart rate, decreasing the afterload, there can be increase in the cardiac output up to 6-fold from the resting state. Okay. So now the question is, when there is an increase in the sudden increase in the afterload, what is the compensatory mechanism? The heart has to overcome the afterload.
Decrease heart rate.
No. That's not the compensatory mechanism. That cannot. You have to do something by means of which you can actually overcome the sudden increased afterload.
The force of contraction has to increase.
Yes, force of contraction has to increase. So what is the one which is helping the force of contraction to increase? When I will give you a clue. When there is a afterload, what will happen to the stroke volume?
Will decrease.
Decrease. Now, when the stroke volume decreases, what will happen to the end-systolic volume and diastolic volume?
Will increase.
It will decrease.
It will increase. So
Yes.
what is this end-diastolic volume known as? It is the
preload.
Preload. You're right, preload. So when there is an afterload increase, the compensating mechanism is increase in the preload, and the heart will be able to overcome it. But when there is a afterload mismatch, the increase in the preload is not enough to overcome the afterload. There can be the body tries to compensate by increasing the preload, but in a patient with real acute increase in the afterload, where there is a mismatch, the preload increase is not enough to overcome it. So they develop acute heart failure. And then, of course, when you treat it, the patient can recover. Are you clear about the hemodynamics of afterload mismatch, and what is the relationship with preload? If it is not clear, I will repeat. It should be very clear. Afterload, when there is a sudden increase in the afterload with all other conditions, all other parameters, hemodynamic parameters remaining the same, heart is failing, that is the afterload mismatch. When there is an increase in the afterload, body compensates by increasing the preload. And when there is an increase in preload, the force of contraction increases, and most of the time, minor alterations in the afterload is well looked after by the change in the preload. But when there is a massive increase in the afterload, a sudden massive increase in the afterload, a preload increase may not be enough to overcome, and that will result in the afterload mismatch. And you should be clear the difference between contractility and force of contraction. Contractility is the intrinsic property of the myocardium to contract independent of the loading conditions, preload, afterload. Force of contraction is the force with which the heart is contracting. And the force of contraction can increase by increase in the preload, increase in contractility, and increase in the heart rate. All these things, is it clear to you?
Yes, sir. Yes, sir.
These things you should be very clear. That is a basis of heart function and the mechanism by which how the heart is compensating, how the heart is improving the performance, all those things. Okay, right. We left from here about third heart sound in aortic regurgitation. Okay, so third heart sound in aortic regurgitation means LV dysfunction. But third heart sound in mitral regurgitation always does not mean there is a LV dysfunction. Okay, there was another question. Between mitral regurgitation and aortic regurgitation, what to choose? So we went from there. So one you already mentioned.
Is it acute or severe?
Chronic.
Chronic. Oh.
Chronic MR, chronic AR. Acute, both are very serious because both can suddenly give rise to acute pulmonary edema and create problems. Mitral regurgitation more likely. Aortic regurgitation also can be quite deleterious. But in chronic MR and AR, one you have already mentioned, MR can give rise to atrial fibrillation, pulmonary arterial hypertension. Is there anything else? What happens? What are the changes when you exercise? When you are exercising, what are the hemodynamic changes in a person when he exercises? What happens? Heart rate?
Heart rate will increase. Peripheral resistance decreases.
Peripheral resistance vasodilation will decrease.
And force of contraction will
increase.
It will increase because of the increase in the venous return as well as increase in the contractility. Now let us look at the effect of these changes on this MR and AR. When the increase in heart rate, what will happen to MR?
Increase in heart rate will
increase MR.
Will decrease AR but increase MR.
Yes, there is a decrease in the increase in the heart rate will increase the systolic time and decrease the diastolic time. So the MR will increase and AR will
decrease.
Okay.
Decrease.
Next point is peripheral resistance. When it comes down,
sir, if peripheral resistance is low, then AR will decrease, sir, and MR will increase.
AR may not, MR may not increase, may remain the same, but there will be AR will significantly be benefited by increase in the regurgitation. Sorry, decrease in the peripheral resistance. And what happens to the pressure when you are exercising? What happens to systolic pressure? What happens to diastolic pressure when you exercise?
Systolic pressure will increase, diastolic will decrease.
Yes. When the systolic pressure increases, what happens to MR?
It will increase, sir.
MR will increase. And when the diastolic pressure decreases, what happens to AR?
It will decrease.
It will decrease. So when you look at the hemodynamics of exercise, it actually is beneficial for AR. The AR comes down because the increase in heart rate, decrease in the diastolic pressure, and also the peripheral resistance all comes down. So AR is benefited. And when the MR is, as far as MR is concerned, it becomes more because the systolic time is more, systolic pressure is higher. All this will result in more MR. So of the two lesions, AR is much more better tolerated during exercise than MR. And patients may come and tell you, I just finished running 5-6 kilometers, and when you examine, you may find the patient is having severe aortic regurgitation. Till the time LV dysfunction occurs, aortic regurgitation is well tolerated. So of the two lesions, aortic regurgitation is much better tolerated, less complications, and has got a much better prognosis. But aortic regurgitation is a lesion which gives rise to the largest LV size. The LV can be quite big in aortic regurgitation. Okay. So is that clear to you between MR and AR?
Yes, sir.
That should be very clear. Okay. So this patient is having, so because of the low pitched mid diastolic rumbling murmur, two possibilities that we discussed. One is mitral stenosis, Austin Flynn murmur. We rule out that most likely it is Austin Flynn murmur. The second possibility, just a minute. Hello? I had a look at the electrocardiogram. Compared to the previous electrocardiogram, there are minor changes. So somebody should evaluate the story properly. Yeah, the electrocardiogram shows a variation, but how significant is the variation can be evaluated only by listening to his story. What happened to him? What is his symptom? And also examining him. I think you should see a doctor. There will be no control. Medicine I can tell you what medicine study first class. Can you tell me? Now, one thing is that if the center value that Okay, second possibility that we want to discuss is whether it is murmur is due to the Austin Flynn murmur or a flow across the increased flow across the mitral valve. And considering that there is no third heart sound, I think we would favor that this could be an Austin film murmur. So all put together, we are concluding that this is an Austin film murmur. And of course, he has got an associated mitral regurgitation, tricuspid regurgitation, and a flow murmur across the aortic valve, most likely secondary to an increased stroke volume. Okay, right, yes. Regarding the etiology, what is your opinion, Agnath?
Sir, regarding etiology, it could be mostly due to the rheumatic heart disease.
Yeah, I think there is a possibility that it could be rheumatic heart disease because he gives a story suggestive of rheumatic fever in his childhood.
Yes, yes.
And so he has got mitral regurgitation as well as aortic regurgitation. And when you have got multiple valve involvement, you must always think of the possibility of rheumatic heart disease. Okay, right, yes. But okay, fine. So, all right. Okay, now we'll go to the, what do you like to see, ECG or X-ray? Any other points somebody would like to discuss? Any other points? Any other etiology? Do you think that this could be Marfan syndrome, which can give rise to both mitral regurgitation as well as aortic regurgitation?
Actually, history, we got history from patients. At the age of 13, he has a history of fever and joint pain.
No. We have discussed that point. So there is a possibility it could be rheumatic fever. I'm asking you that, okay, do you like to entertain a possibility of Marfan syndrome also?
Sir, Marfan syndrome, we get this early diastolic murmur mostly on the right side, sir. That is one differentiator.
Okay, that's
okay. Second,
in mitral regurgitation of Marfan syndrome is mostly due to what?
Annular dilatation.
Annular dilatation, and they can have mitral prolapse also.
Prolapse, yes.
So here there is no clinical findings to diagnose prolapse because this is a pansystolic murmur and the S1 is feeble, there is no ejection click. All put together, the Marfan cannot be given a high priority, but definitely because of the rheumatic fever story, I think that would be the first possibility. Okay, now we'll go to the ECG. Would you like to see the ECG first or X-ray just?
ECG, sir.
ECG. Okay. Can you see the ECG? There is some shade, but can you see it?
Yes, sir.
Okay, right. Interpret the ECG. Only salient findings. You need not spend too much time on reading it, but you tell me most important findings.
Sir, most important finding is LV, elevated LV strain pattern is there, sir.
Okay. What do you mean by LV strain? Is better not to use the word LV strain. STT changes.
STT changes are there.
In which type of LV hypertrophy? Whether it's volume
pressure
overload?
Type of. Actually, LV STT changes. STT changes we get both in actually pressure and volume types, sir. But in pressure type we get ST depression and volume overload we get ST elevation. Sir.
Okay, we can get a concave ST with upright T waves in volume overload. Downsloping ST with T wave inversion in pressure overload.
Pressure overload.
Okay, so here what is this? And what are the other QRS changes of pressure load or load and overload, volume overload?
Sir, in volume overload, first we get Q waves in lateral leads, V5, V6.
Okay.
Second is a tall R wave is there, sir. It's
Very
around
good.
some 50 ml like that.
Very
one.
good. Very good.
Second, third is, sir, there is a symmetrical tall T waves, or tented T waves, we can
Very
say.
good. So deep Q waves, deep narrow Q waves, tall R waves, and upright T waves are the features of volume overload.
Overload.
Pressure overload features?
There is a sir, shall I take criteria or?
No. The pressure overload. Feature. What are the electrocardiographic changes?
We get tall R waves. Tall R wave.
R wave may not be very tall. It can be. You can sometimes get, but more important is that width of the R wave will be more. The intrinsic deflection time or the
intrinsic it's more than 0.05, sir.
Okay, 0.05. That's very good.
Then QRS is more than 0.09.
Very good, excellent. And STT changes.
STT changes, sir.
Here, what is happening here? Is it volume overload, pressure overload, or a combination?
Looking combination, sir.
It looks like a combination because the patient is having a tall, narrow QRS with STT changes, so it could be a combination of volume with pressure overload. Do you think that this ECG shows the, if you want to improve upon this ECG, can you repeat the ECG with some modification?
Sir, actually, by increasing the voltage,
increasing the voltage, what do you mean by that? Can you improve upon this ECG by making mild alteration in the recording? Any one of you?
The chest lead to be taken with a lower voltage, sir.
Very good. Excellent. Not lower voltage.
No, sir, 5 millivolt we have to take.
Lower space.
That is standardization.
No, that was not the correct answer. The correct
standardization has to decrease, sir.
No.
Lower space to be
it should be taken one space down. Chest lead should be placed one lead down. And what is the reason?
So then,
apex shifted.
Apex is down and out. So if you think that the LV forces are not fully picked up, you can take electrocardiogram chest leads one space down, and the LV forces will be better picked up, and you'll get a much better idea. Because the apex beat is in the fifth left intercostal space, sixth left intercostal space, almost in the anterior axillary line. So if you keep one space down, the forces will be much better picked up. Okay, so if you want to, I wanted to take one space down by the time the patient left. Otherwise, I could have taken that also and shown the difference to you. So you should always take, whenever you think that the apex beat is down and out, you can take one space down, and that will pick up the forces much better. Okay, what about the left atrial enlargement, all those things, because you are suspecting mitral regurgitation?
Left atrial enlargement is not there, sir. Actually, it's not, but it's not looking, sir.
Yeah, I also agree with you. There is no left atrial enlargement. So obviously that means mitral regurgitation is not.
It's a severe, sir.
Severe. It should be either mild or low moderate, not very severe mitral regurgitation. If it was there, we would have expected the patient to have left atrial overload pattern, left atrial dilatation. It is not there. Okay, so does this electrocardiogram help you to make a positive diagnosis of aortic regurgitation? Just a minute. Hello? I think I can, the medicine that can be started, I can send you a message. Okay, I'm sorry, in between few disturbances. Okay, so the ECG favors more aortic regurgitation than
mitral
regurgitation. Okay, so aortic regurgitation is one condition where you can get both pressure as well as volume overload. Especially in this patient, he had a slightly elevated blood pressure, is hypertensive. So his changes may be partly because of the hypertension, aortic regurgitation, where both volume as well as pressure overload is possible. Patients with aortic regurgitation can have relatively less of ischemic, they can have higher risk of developing ischemia. Why it is so? How the aortic regurgitation can have ischemia?
Sir, in aortic regurgitation, actually, heart get blood supply during the diastole, sir, actually.
Okay.
In case of aortic regurgitation, diastolic pressure has decreased. So that is one reason. And other is also...
You have to explain it. No, that's not enough. You should tell me the hemodynamics. So the aortic diastolic pressure, what is the coronary perfusion pressure?
It will be decreased because diastolic pressure is decreased and LV EDP has increased.
Yes, coronary perfusion pressure is LV diastolic pressure. Sorry, aortic diastolic pressure minus LV and diastolic pressure. So if there is an decrease in the aortic diastolic pressure and increase in the LV diastolic pressure, that will result in a low coronary perfusion pressure. So the coronary perfusion suffer. Okay, next
also, one. Increase the diameter due to dilatation. Yeah. Increase workload of the heart.
So because of the increased workload, because it has to contract and pump more volume of blood, more myocardial oxygen demand is there, and also the total myocardial mass is also increased. So there is a larger amount of blood should be reaching the myocardium. So because of all these things, patients with aortic regurgitation can sometimes have a low coronary reserve. And because of the low coronary reserve, they can develop ischemic symptoms at a very low stress. And presence of nocturnal angina is considered as one of the manifestations of severe aortic regurgitation. Can you explain that? How can nocturnal angina in aortic regurgitation can precipitate ischemia?
Reduce sympathetic.
Okay.
Reduce heart rate.
Heart rate is less during the sleep. Actually, it's related with sort of sleep cycle. Some nocturnal.
No, so you have to tell me what are the hemodynamic changes of sleep which can increase or decrease ischemia. What happens to the diastolic pressure when you sleep? The heart rate comes down. So the diastolic pressure.
Sleep, the parasympathetic stimulation will lead to more vasodilation and diastolic pressure fall more during the sleep hours. Yeah, so the coronary perfusion decreases more in the night.
Very good. 1, 2. So there is a decrease in the coronary perfusion because of the lower diastolic pressure. Okay. 2. When there is a in a patient with aortic regurgitation, when there is a long what happens to heart rate at night? Decreases. When the heart rate decreases, what happens to diastolic blood pressure? When the heart rate decreases, what happens to diastolic blood pressure?
It will increase.
Regurgitation will increase.
Regurgitation will increase.
Regurgitation will increase. The aortic diastolic pressure will come down. The LV diastolic pressure will go up. So the coronary perfusion pressure will further come down. And when the heart rate decreases, what happens to myocardial oxygen demand?
It will decrease, sir.
It will decrease. So at night there are 2-3 changes which will actually increase the ischemia, but there is one important change which will decrease the ischemia. So actually ultimately the net effect of this will result in whether the patient can have nocturnal angina. And nocturnal angina is one of the clinical signs of severe aortic, clinical symptoms of severe aortic regurgitation. Okay. So from here we'll go to the exercise. X-ray chest. X-ray chest. Or anybody who would like to interpret the X-ray chest? X-ray chest, what does it show? What are the things that you're planning to look at?
X-ray chest PA view showing that cardiomegaly is present.
Significant cardiac enlargement, LV type, RV type?
It's difficult to say.
LV type, because actually it is dipping down and then the apex seems to be an LV type of cardiac enlargement. Yes, what else? What is the other chamber that you would like to diagnose?
Yes, sir. Sir, aortic, sir, aorta is dilated, sir.
Aorta is dilated, very good. Ascending aorta is dilated, significantly dilated. Yes, very good.
Sir, LA enlargement is there.
There is a suspicion, but not very classical. There is a suspicion that there is a minor elevation of the horizontal. There is elevation of the left bronchus, indicating that there may be some degree of enlargement. But at the same time, I am not able to make out the left atrial appendage. Left atrial appendage is not seen, but there is a suspicion about the slight lifting up of the left bronchus. So I will be neutral. I won't commit to it, but there is a suspicion LA may be slightly enlarged. Okay.
Significantly enlarged.
RA. No, but this seems to be lower down. There is not much of an enlargement, but it's upper one, and this portion is formed by the ascending aorta. So I would favor ascending aorta rather than the right atria. Okay, upper lobe vessels. Any evidence of any pulmonary congestion? Not a good X-ray, but obviously there is not much. Okay, so does this the X-ray also favors the diagnosis of aortic regurgitation? And here we have to think that there is an ascending aortic pathology which might have contributed to the aortic regurgitation also. Okay, now we'll go to the echo findings. Any volunteers can do, or Raghunath can do it. Anybody would like to interpret?
It's a parasternal long axis view, sir. It's showing the severe AR.
Okay. There is a severe AR. What about the aortic size?
Sir, aortic root is very much dilated, sir.
Yes, aortic root is significantly dilated.
And sir, LA is compressed by that aortic root dilatation. Yes. And sir, there is no sign of rheumatic heart disease possibly, sir.
You can't be certain. What is your opinion about the PML?
The PML, sir, it is moving well, sir. Little, if I say, I would say little prolapse only, not the restricted movement.
It is not classical, but I would consider that there is some degree of restriction of the PML, because PML is not completely moving out, but there is some restriction, but not the classical rheumatic. I agree with you, but there is some restriction of.
And sir, aortic valve, sir, it looks there is an eccentric closure.
Okay, fine, agreed. And do you want to make any comment about AML? What do you expect in AML in a patient with severe aortic regurgitation?
Sir, fluttering movement of AML.
Yeah, fluttering movement. Do you think that there is some fluttering movement?
Sir, may be possible because sir, there is a spontaneous echo contrast is seen in the LVOT. Yes, during diastole, sir.
Yes, there is some degree, but you can always you can also see that there is some degree of the flutter or some vibrations of the anterior mitral.
So that will be better view in M mode.
Oh, M mode, of course, it will definitely give you the clue. But I'm asking whether in 2D can you think that there could be some degree of anterior AML flutter?
No evidence of any
Okay, so we'll go to the next one.
So LV is dilated and the wall is little thickened, sir.
Yeah, LV is dilated. There is some thickening of the LV myocardium. Okay, now what do you think about the mitral regurgitation?
Mild mitral.
Maybe more than mild. I would have thought that it will be moderate mitral regurgitation or low moderate mitral regurgitation. It is not. We'll have to look at the apical 4-chamber view also before you draw conclusions. and aorta is hugely dilated. And this is the aortic size. What is the normal size of the aorta, and what is the at what level do you call it aneurysm, and what is the level at which you think that there's a higher risk of developing rupture of the aorta? What is the normal upper limit beyond which you will call it aneurysm, and what is the level what is the level at which you think that there is a risk of developing a rupture of the aorta?
The upper limit is 4.5.
Yeah, more than 4 is
upper limit. And 5.5 is the, we can say it could be.
Yes, when the aortic size goes beyond 5.5, there is always a risk that the patient can go in for aortic
rupture.
Yes, sir. It is a
5.
Here it is grossly enlarged. It has gone up to 7.6 centimeters. Very gross enlargement. I'm seeing for the first time such a huge aorta. Aortic size, when it goes beyond 5.56 and all, there is always a very high risk that even a minor trauma is enough to rupture the aorta.
Yes, sir.
So it's a huge aorta. Okay, right? Yes. And here is the M mode. Saroj.
Yes, sir. Fluttering movement is very well seen here, sir.
Yes, there's
of the AML.
You can easily see the flutter movements. So
yes,
the flutter movements, which is suggestive of the
significant aortic regurgitation.
Aortic regurgitation and the jet of the aortic regurgitation striking
falling on AML.
On the angina mitral leaflet. And here is the measurements. The interventricular septum during diastole is 1.6 centimeters, and the posterior wall also is 1.6. So there is a significant concentric left ventricular hypertrophy, which may be partly due to the aortic regurgitation itself, but mostly may be related to, he's a hypertensive, so that may be the reason. And he has got an ejection fraction of 60%, but the end-diastolic volume is 273, grossly elevated end-diastolic volume. LV internal, LV size also is 7.2. What is your interpretation about the LV end-diastolic dilation?
Sir, more than 7 centimeter LV end-diastolic volume is poor prognosis, sir.
Yes. So what really happens? What happens?
Sir, it is
when there is a stretch in the LV, what will be the force of contraction? When there is a stretch of LV, what will be the force of stretch? Is actually increase in the preload. So what will happen?
Increase the increase the
force of contraction. Not use the word contractility. Increase force of contraction. When it goes beyond 7, what happens?
Sir, rather than
when there is a LV diameter goes above 7 centimeters, what happens to force of contraction?
So it starts reducing gradually.
Yeah. Above 7.5 definitely decreases, and above 7, between 7 and 7.5, it may start decreasing. So if you look at the ventricular rolling curves, till about it goes on increasing as the stretch increases up to about 7, and when it goes above 7, then gradually starts decreasing. So when the LV diameter has gone beyond 7, there is every reason for you to be very careful that the patient can develop significant LV dysfunction. Even after aortic valve replacement, the patient may do extremely bad because they may not improve because the LV is overstretched. So LV 7 is the cutoff. Above 7.5, definitely the LV function, the preload, increasing the force of contraction of the LV actually acts will not have any more effect. Actually, at 7.5, the force of contraction with the stretch of the LV actually it has got the opposite effect. It decreases, and the patient can have a lot of LV dysfunction. So 7 is you can consider 7 as a end-diastolic dimension. 7 can be considered as a point for you to consider that the patient immediately needs a surgery. Otherwise, he will go for all types of trouble. Okay, right? Yes.
And sir, here PML, sir, PML in M mode, sir.
PML in M mode is moving posteriorly. So I agree with you that it's not the classical traumatic, but you can think that there is some restriction of movement. That's all.
Yes,
so,
sir. Yes, sir.
Right. Okay, you are right. Okay, right. Yes. What do you find in this? Please concentrate on this one. Please concentrate on this echo image.
Aortic wall.
Yes, aortic valve is abnormal. And what is this? You are saying something inside. What is it?
Sir, it is the cusp looks 3 in number only, or 2, sir. Sir, 2.
Oh, what is this one? Is it a cusp or something else?
Sir, maybe.
Because it fuse cusp.
Sir, it is not cusp, sir.
Yeah, what is it? Because you are saying that it is continuously and it is not opening and closing. And what is it?
Yeah.
Rapid.
So whether some dissection flap has come.
Very good, excellent. It's a healed dissection flap. Actually, this is a healed dissection flap. It is not an acute dissection, but it is an healed dissection flap, and this is the valve. Okay,
And
right.
sir, valve is bicuspid only, no, sir?
I'm not certain. It seems I can see only because he had undergone a valve repair. So there is some difficulty in interpreting the valve, but it seems that it may be a bicuspid aortic valve which has undergone a repair. Okay, now okay, what is this now? You can see it took us very well here, and probably there is something more, which is actually the dissected flap. So interpret the what you see here, and what you see here, and what you see here. Agnath, would you like to take up the challenge?
Sir, maximum aortic regurgitation is coming from the right coronary cusp.
Okay, right, yes.
And sir, in the second view, sir, that is, sir, I think supraesternal. There is a flow reversal.
No, that's not supraesternal. It is actually the short axis view. This is aorta. I'm going to give you a clue. This is aorta, and this is what is this? If that is aorta, then what is it?
Reversals.
Sir, coronary artery.
Not coronary artery. It is actually the aorta is pressing on the pulmonary artery,
sir.
pulmonary artery and producing a stenosis, and is going right to big turbulence. And you can see there is a gradient across the pulmonary outflow, which is near about 3.64, and the gradient will be 54 point, around 53, more than 50. So this is actually an aorta is pressing on the pulmonary artery and giving rise to pressing on the pulmonary artery, giving rise to turbulence in the pulmonary arterial flow. You can see the pulmonary artery is distorted. The patient is having some degree of pulmonary regurgitation also. Okay, right. Now, what is this? LV function is when the patient is having mitral regurgitation as well as aortic regurgitation, 60% ejection fraction, will you interpret it as normal or abnormal?
Sir, abnormal, sir.
Abnormal. See, whenever there is mitral regurgitation and aortic regurgitation, even 60% can be considered as evidence of LV dysfunction. Yep. And what about the mitral regurgitation? How much is the mitral regurgitation?
So now significant, sir. Moderate at least. Central jet of MR is seen, sir.
Yes,
reaching to the pulmonary vein.
Yeah, it is we have to consider this at least moderate mitral regurgitation. And what is the interpretation of the LV diastolic function?
Sir, it is 3, type 3, sir. E is too much more than A.
Oh, okay, yes.
And
what are the type 1, what do you, grade 1, grade 2, grade 3, grade 4 diastolic dysfunction? Agnath, let Agnath try. Agnath, what is grade 1, grade 2, grade 3, grade 4 LV diastolic dysfunction? Anybody would like to say grade 1, what is grade 1, grade 2, grade 3, grade 4? These are all things you should know completely. These are all questions which will be actually asked in the clinical examination. Grade 1, grade 2, grade 3, grade 4 diastolic dysfunction.
E by A ratio in grade 1 is
you're right, E by A ratio.
less than 0.8, sir. And E velocity will be less than 50.
Okay, right. Yes, that's grade 1. Very good. Grade 2?
So grade 2 can be when the E by A ratio is between 0.8 to 2, or when the E by A ratio is less than 0.8, but the E velocity becomes more than 50.
Okay. One more point. Then you will have to look for one more point.
Deceleration time.
Yeah, what is the deceleration time? Very good, excellent.
So from the peak of the E2 to the baseline time taken.
Yeah, and what should be the deceleration time? It will be increased or decreased?
So in diastolic dysfunction, it will decrease.
Decrease. What will be the value roughly?
So, 110 or something. Sir, I don't remember exactly.
No.
Milliseconds.
Less than 140.
Yeah, less than 130. Very good. Very good. Even 160 is abnormal, but less than 130 is definitely abnormal. So you look at the E by A ratio, and also you look at the deceleration time, which is a new pseudo normalization. And grade 3?
Grade 3 when E by ratio is more than 2.
Yeah, we give E by A ratio more than 2, and deceleration time is less than 130. And grade 4, and is reversible. Grade 4?
Yes, sir. Grade 4 when it is not reversible.
Not reversible. So all students should know the LV diastolic dysfunction grade 1, grade 2, grade 3, grade 4. This will be a stock question. And according to interpretation, what is the level of diastolic dysfunction in this patient?
Grade 3.
Grade 3. At least definitely is grade 3. Very good. I think you answered it very well. Okay, grade 3. Okay, now what is this? Can somebody whose dog is barking, can you mute yourself? Can somebody whose dog is barking, can you mute yourself so that it does not disturb the class? Okay, E prime interpretation.
E prime.
What is the normal E prime, and by E prime what do you measure?
So we measure the ratio of blood inflow velocity versus the tissue velocity.
Very good.
Sir, medial annulus and the lateral annulus. We
Very
take
good.
separately, sir.
Yes.
Sir, lateral annulus, sir, the ratio will be more, whereas in case of medial annulus, it will be less.
All other way around.
Other way around.
Sir, lateral is moving more.
Yes.
So, lateral is moving more, so ratio will.
So E by E prime ratio will be?
Less, sir.
Yes. Usually it will be around 8 in if you take the lateral, and if you take the medial, it can be 10 to 11, up to 10, something. And when you consider this abnormal?
When E by
15.
is more than 15.
Yeah, more than 14. More than 14. 15 and above is abnormal. And when it is 15 and above, what is your interpretation of the pulmonary
venous pressure? Yes, sir. 25.
No, not 25. Anyway, it is more than 15, and it can be anywhere up to 25. So whenever it is more than 15, E by E prime is more than 15, the LV and diastolic pressure and LA pressure and the pulmonary venous pressure can be more than 15. And the patient can go for pulmonary edema also. So the E prime will give you a good idea about the pulmonary venous pressure and whether the patient is having LV diastolic dysfunction. Okay, this patient is having, by different parameters, we have proved that the patient is having significant LV diastolic dysfunction. Okay, what is this?
The tricuspid regurgitation.
That's very mild tricuspid regurgitation. Only tricuspid regurgitation is mild and okay, right. So also shows aortic regurgitation. And what is the aortic pressure half time?
It is only 192. It is severe ARs.
Severe ARs.
Oh, severe ARs. So by aortic pressure half time is one parameter by means of which you can assess the severity of aortic regurgitation. And what is the cutoff point?
Sir, 200 and 450, sir. If it is less than 200, it is severe.
Oh, okay.
200 to 400.
Mild.
Okay. Right. Okay. Right. Yes. Oh, all right. So the throat showing severe aortic regurgitation, huge left ventricle, aorta is dilated, and there is no ASD. Okay. What does this show? The suprasternal notch view.
Diastolic reversal.
Diastolic reversal. And for you to diagnose severe aortic regurgitation, what is the criteria?
It's a pan-diastolic flow reversal.
Yeah.
Hollow diastolic reversal.
Hollow diastolic reversal with the end diastolic reversal velocity should be equal to or more than? What should be the end diastolic velocity? Reversal velocity. More than 20 centimeters per second. If the end diastolic flow reversal velocity is more than 20 centimeters per second, that is diagnostic of severe aortic regurgitation. You look at the flow reversal in the descending thoracic aorta, and the end diastolic, this is the end diastolic, somewhere here is the end diastolic, and if the end diastolic velocity is more than 20 centimeters per second, it indicates severe aortic regurgitation. So diastolic flow reversal, you can see that diastolic flow reversal here, very good.
Yes, sir.
I mean, you know, this is a, so you can just see that also. This is a CT, and tell me what you find here.
So there was a small dissection flap that was seen.
Very good. There's a dissection flap seen. Very good. Excellent. There's a dissection flap seen. You can see. I'll show you when it comes. Now you can see. So there's a dissection flap seen in the ascending aorta. There's a dissection flap in the ascending aorta. Okay, so there is huge aorta, and the aorta is pressing upon the pulmonary artery, and there is a dissected flap. Okay. Now coming to the final diagnosis.
Rheumatic heart disease is probable congenital bicuspid aortic wall, severe aortic regurgitation, moderate to severe mitral regurgitation, failed aortic wall repair, fusiform ascending aortic aneurysm, which is compressing the main pulmonary artery and the right pulmonary artery, dissecting aneurysm of the ascending aorta, mild tricuspid regurgitation, cross-artery LV with the satisfactory LV systolic function, LV diastolic dysfunction, then systemic hypertension, treated left ventricular failure.
Okay. So these are the various clinical findings that we have observed. We can do a short discussion. Aortic regurgitation etiology. So it may be due to a valvular pathology or a vascular pathology. Eknath, would you like to read so that?
Yes, sir, I will read, sir. Aortic regurgitation etiology. First is the valvular rheumatic heart disease, infective endocarditis. It could be congenital, calcified, degenerative aortic wall, trauma, prolapse of the aortic cusp in ventricular septal defect. Subaortic stenosis is associated with the aortic regurgitation in 85% of the cases.
Stop at that level. Why? How can subaortic stenosis give rise to aortic regurgitation?
Jet hitting the aortic valve.
Very good.
Membrane is present.
Yeah, yeah. No. Who said that jet is hitting the aortic valve?
Sir, Sayyid Imran sir from KAP Medical College.
Oh, yes, yes. That is because there is a forceful jet from the the subaortic stenosis, which hits against the aortic valve and damages it and give rise to aortic regurgitation. So, in about 85% of cases of subaortic stenosis, there will be associated aortic regurgitation. May not be severe, but maybe mild or low moderate. Okay, right. Go ahead.
Then complication of the balloon aortic valvuloplasty.
And when do you recommend balloon aortic valvuloplasty? What are the situations where you can recommend balloon aortic valvuloplasty?
Sir, congenital aortic stenosis.
Very good. Congenital aortic stenosis in the first or second decade. Excellent. Very good. Second.
And secondly, if the patient is having comorbid condition, surgery is not possible in adults also.
But adults, it is not usually recommended. Why it is not recommended?
The valve is usually calcified.
Yes.
So any attempt to it will dislodge the calcium, causing a stroke or acute coronary syndrome.
Okay, it can give rise to it can damage the it can destroy the calcium. Okay. More important is that even if you open the aortic valve, there is a high chance of developing restenosis of 70 to 80% within about a year. So it is not effective. But previously there was a recommendation that it can be used as a bridge to aortic valve replacement. What is it? Bridge to aortic valve replacement.
To prepare the.
You want to tell me what is the condition where you are trying to bridge?
LV dysfunction is there at that time.
Yeah. If the patient is having severe LV dysfunction and which makes the surgical procedure a very high risk procedure, you can temporarily open up the aortic valve and the LV function can, there can be some improvement in LV function and the patient can be taken up for the surgical procedure at a lower risk. That is known as a bridging procedure before aortic valve replacement. Okay, right, yes. So complication of aortic valvuloplasty, there can be aortic regurgitation. Yes, what else?
Then Takayasu disease and the sublupus erythematosus.
Okay, right. These are the valvular pathology which can give rise to aortic regurgitation. Vascular pathology?
In vascular pathology, systemic hypertension, Marfan or the Marfan-like conditions, the aortopathy, as in case of bicuspid aortic valve, in case of syphilis, weight reduction drugs, aging, peripheral disease, Crohn's disease, osteogenesis imperfecta, ankylosing spondylitis, Paget disease, psoriasis, giant cell arteritis, relapsing polychondritis.
All these conditions have been associated with aortic regurgitation, but at least you should know a few conditions. Of these, which are the ones which you consider when the patient is coming with aortopathy? This patient is having a huge aorta.
Marfan syndrome.
Marfan syndrome, yes.
Bicuspid aortic wall also
very
get.
Good.
Syphilis we get.
Syphilis.
Yes, very good. So you can have dilatation as well as stenosis, but ascending aorta is not commonly affected in. Usually it affects some the arch vessels and abdominal thoracic, abdominal aorta, and not very common to that. Yes.
The bicuspid
osteogenesis imperfecta also can can also give rise to huge aorta. Okay, right? Yes. So
the bicuspid post-aortic dilatation, sir.
Post-aortic dilatation, and also it can have a genetically weak aorta, which can actually become very huge. So aortopathy, when you are asked a question, the conditions that you should mention are: one is Marfan syndrome or Marfan-like other situations like Ehlers Danlos, all those can give rise to huge aorta. Aortopathy in a patient with bicuspid aortic valve, Marfan syndrome, syphilis. Then it can osteogenesis imperfecta can have huge aorta. So these are the few conditions where you can think of ankylosing spondylitis sometimes can give rise to huge aorta. So these are the conditions where you should think of when you are seeing a patient with atherosclerotic aortic aneurysm can happen. And aging process also, gradually aorta can become weak and become large, but may not become huge. So aortopathy is a condition where there is a dilatation of the aorta, and including the aging process, there are a number of reasons for aortic dilatation. But 2-3 conditions you should immediately think about when the aorta is very huge are Marfan syndrome, aortopathy, syphilis, aortopathy in a patient with bicuspid aortic valve, syphilitic aortic aneurysm. It can happen in ankylosing spondylitis. It can happen in giant cell arteritis. So these are the few conditions you should cross your mind when you're seeing a very huge aorta. Right, okay. So how to
how to differentiate between the valvular and the vascular? In case of valvular, murmur best heard at the third left intercostal space along the left sternal border. S2 is feeble, no ejection click except in bicuspid aortic wall.
Okay.
In case of vascular, dullness of the second right intercostal space murmur better audible on the right side of the sternum. S2 is loud. Ejection click may be audible.
Because of the dilated vessel, you may be able to hear and appreciate the ejection click. Okay, right. Very good.
Assessment of severity of aortic regurgitation by clinically nocturnal angina, peripheral signs, down and out apex, LV type, feeble S1, paradoxal state S2, length of the end diastolic murmur.
Early diastolic murmur.
Early diastolic murmur, at least 50% of diastole, except in case of acute aortic regurgitation. Early peaking ejection systolic murmur at aortic
area.
Then ostium fringe murmur. S3 indicate the LV dysfunction in case of the AR.
So these are the clinical signs by which you assess the severity of aortic regurgitation.
Then ECG, LV mostly volume overload, associated STT changes indicate the constant LV hypertrophy.
Yes.
X-ray chest suggestive cardiomegaly, cardiac apex dipping down below the diaphragm, features of the heart failure.
In the X-ray, if there are upper lobe vessels prominent, all indicate severe aortic regurgitation.
This echocardiographic assessment of the AR. The first is regurgitant volume in ml. In case of mild, we get less than 30 ml, moderate 30 to 59. In case of severe, more than 60 ml.
Okay, very good.
Regurgitant fraction. In case of mild, less than 30, moderate 30 to 49. In case of severe, more than 50%. So 50 ml. Okay. Vena contracta.
No, 50 ml, 50%.
Yes, 50 ml, sorry.
Yes.
Vena contracta in millimeters. In case of mild, it's 3 mm. In moderate, 3 to 5.9. In case of severe, more than 6 mm. Then regurgitant orifice in centimeter square. In case of mild, less than 0.1. In moderate, 0.1 to 0.29. In case of severe, more than 0.3. Then jet width. Jet width in case of plug sleeve, less than 25% of LVOT. Is it, sir?
Yeah, it is LVOT.
Yes, right. Yes. In moderate, 25 to 64.9%. In case of severe, more than 65%.
Very good. Yes.
Then area of regurgitation.
Area of regurgitant jet measured from the parasternal short axis view.
Short axis view. In case of mild, less than 5%. In case of severe, more than 60%. Pressure of time measured in milliseconds. In mild, more than 500. In moderate, 200 to 500. In case of severe, less than 200. Diastolic flow reversal.
Thoracic aorta.
In descending thoracic aorta.
End diastolic velocity.
More than 20 centimeters per second.
Okay. So these are the various echo parameters. At least few you should remember. The examiners may ask you how will you assess. So you should be able to answer at least few of them. You can look at the regurgitant volume, regurgitant fraction, or vena contracta, and also pressure half time. And if there is a diastolic flow reversal, there can always be a question about the diastolic flow reversal in the descending thoracic aorta. Okay, right, good. So this is the same thing. Now the interesting features in this case, a case of bicuspid. You can read, Egnath.
A case of bicuspid aortic wall with aortopathy and hilt dissection, having a severe AR. Isolated severe AR without AS is a rare in bicuspid aortic regurgitation.
No, bicuspid aortic wall.
Sorry, bicuspid aortic wall. Silent aortic dissection, unusually large ascending
aorta.
Ascending aorta. Diameter of unusual segment.
Unusually large ascending aortic aneurysm.
Aortic aneurysm. Diameter of unusual segment is 7.6 centimeter by echo and 7.7 by CT angio. Then the ascending aortic aneurysm needs intervention when the diameter reaches 4.5 centimeter, the risk of aortic rupture is significant when the size reaches 5.5 centimeter of diameter. At 6 centimeter of the diameter, the aortic rupture can occur with a minimal provocation.
So that's the most important you should know, because he has got a very hugely dilated aorta, and even at 6 centimeters, the risk of an aortic rupture is very high. Okay, right? Yes. This you should always remember. And the values are 4.5, 5.5, and 6. Okay, right? Yes.
In our patient, this unusual feature can be explained by the failed aortic wall repair the patient underwent. The severe AR must be sequel to the failed aortic wall repair. The healed aortic dissection, fibrosis around the aortic area as a sequelae to the aortic surgery must be protecting the patient from the aortic rupture.
Maybe I was thinking that whether because of the previous surgery, there must be some fibrosis in and around the aorta, whether that was protecting him from going in for aortic rupture. Okay, yes. Bicuspid aortic valve.
Bicuspid aortic valve affect the 1 to 2% of general population. Associated lesions are the ascending aortic aneurysm, aortic dissection, and the coarctation of aorta. Aortopathy in bicuspid aortic valve may be related to the genetically weak aortic wall or the abdominal aortic wall shear stress due to helical flow pattern in the aorta or the both. As per various
abnormal aortic flow pattern because of the eccentric opening of the bicuspid aortic valve, and also there is a genetically weak aortic wall. Both may be contributing to development of aortopathy. Okay, right? Yes.
As per various reports from the tertiary care centers, the incidence of aortopathy in bicuspid aortic wall is as high as 25 to 40%.
This is a report from the tertiary center, and only patients with complications will go to tertiary center. So this cannot be taken as the correct value of the development of aortopathy in a patient with bicuspid aortic valve, because in the general population, there may be a good number of people with bicuspid aortic valve walking around without any symptoms. So this value, we can say that patients coming to a tertiary care center, the reports say that the aortopathy in a bicuspid aortic valve is as high as 25 to 40%. Okay, right? Yes.
In patient with aortopathy, the aortic aneurysm growth rate is 0.4 to 0.6 millimeter per year.
There is a growth of the aortopathy, aortic aneurysm is found to be around 0.4 to 0.6 millimeters per year.
Cystic medial disease of aorta associated with the bicuspid aortic wall can be predisposed to the aortic dissection. Lifetime risk of aortic dissection in bicuspid aortic patient is 4 to 8 fold compared to the general population.
Yeah, that's what I remember, that bicuspid aortic valve patients have got a significantly higher risk of developing dissection.
Aortic dissection.
Yes.
In a follow-up study of 416 patients of bicuspid aortic valve for 6 years, the incidence of aortic dissection was 3.1 per 10,000 patients year.
Okay. Okay, right. Go ahead.
The risk of aortic dissection in a patient with bicuspid aortic wall and the ascending aortic aneurysm is 5.3 centimeter. Of 5.3 centimeter is 4%.
So that is much higher. Once the aorta becomes large and the aortic aneurysm has developed, especially reached the level of 5.3 centimeters, he has got a much higher risk of developing aortic dissection. Okay, very good.
Follow-up recommendations. In patient with normal initial aortic diameters by transthoracic echocardiography, the thoracic aorta should be re-imaged every 3 to 5 years.
This is what should be the correct follow-up for a patient with bicuspid aortic valve. When you detect a bicuspid aortic valve in a routine examination in echo, what should be your advice? Okay, right? Yes. So if everything is normal, once in 3 to 5 years.
In a patient with initial aortic dilatation, root or tubular ascending aorta measures 40 to 49 millimeters. The thoracic aorta should be re-imaged at the 12 month. If stability is confirmed, then re-imaging can be performed every 2 to 3 years.
Yeah, so if the aorta is dilated, you should do one more repeated examination at the end of a year. If it is stable and there is no more growth during this 1 year period, then you can re-echo once in 2 to 3 years. Okay, right? Yes.
In a patient with more advanced initial aortic root dilatation, rotatubular ascending aorta 50 to 54 millimeters. The thoracic aorta should be reimaged at least every 12 months. A year.
Once it is huge aorta, you should be very careful and you should image it every 12 months. And as soon as there is the criteria for aortic valve surgery, aortic surgery should be carried out. Okay, right? Yes. If anybody has having any doubt, whenever these things are presented, you can always interrupt me and ask for explanation.
Treatment of AR, medical management first. Mild to low moderate AR follow, then moderate to severe AR. Vasodilators like nifedipine, amlodipine, heterolazine, AC inhibitors of the ARBs. Then AC inhibitor have shown to reduce the mortality in AR based on Scottish registry data. It is possible that AC inhibitors can reduce the interstitial fibrosis, thereby retarding the ventricular remodeling.
Yes, the studies have shown in that Scottish registry. It's a retrospective study. They have found that the patients with aortic bicuspid aortic aortic regurgitation who are put on AC inhibitors have got a lower mortality. So one of the explanations of it is that AC inhibitors can and ARB also can reduce the interstitial fibrosis and thereby retarding the ventricular remodeling. So patients with moderate to severe aortic regurgitation will benefit by AC inhibitors bar ARB, thereby reducing the risk of complications and has got a better longevity of life. Okay, right? Yes.
Sir, shall I interrupt you, sir? 1 second.
Yeah. Yes.
Sir, new guidelines, they said that if you decrease the afterload in case of aortic regurgitation and MR is there, then decreasing the afterload AR will definitely decreases, but LV becomes small and it causes the mitral prolapse, prolapse of the mitral wall, and it increases the MR. Is it like that?
No, when the LV becomes very small, see for that for the mitral prolapse to occur because of the LV becomes very small, it has to be really small. So after mitral prolapse is due to a the cavity podopapillary mismatch. So when the LV becomes very small, patient can develop mitral regurgitation. That's one best example is ASD. When the LV is very small, you can get a mitral prolapse in a patient with second wave ASD. But that is that you have to bring down the size of the LV to very low level. I don't think that will be possible. And actually, even though there was a recommendation that the patients benefit by giving a peripheral vasodilator, I don't agree to that because already with the aortic regurgitation, peripheral the vascular resistance is extremely low, and further lowering is extremely difficult. So a concept that drugs like AC inhibitors and ARB can reduce the interstitial fibrosis is probably acceptable. But of course, Rahmatullah has done the initial work. He has shown that patients with acute patients with aortic regurgitation, if they are put on nifedipine, a follow-up period was very short. But during this period, he found that patients improved and their function improved. So there is a recommendation that vasodilators like nifedipine can be used in the treatment of acute, in the treatment of severe aortic regurgitation. In AC inhibitors, I usually give a combination of AC inhibitors with a calcium channel blocker because there is some data that AC inhibitor can reduce fibrosis and also may contribute to peripheral vascular resistance reduction, and ultimately it may be beneficial. So you can give a combination. I do that, and I found that patients show they are feeling better. So I don't have a real correct data, but from the patient's impression, I feel that this combination has been useful.
Okay.
Yes. Yes.
Surgical treatment indications: symptomatic severe aortic regurgitation. For symptomatic severe aortic regurgitation provided left ventricular ejection fraction is less than 50%.
It's class 1 indication.
It's a class 1 indication. Along with other open heart surgical procedures, then left ventricular end systolic diameter more than 50 mm, that is class 2A indications. Left ventricular end diastolic diameter more than 65 mm is a class 2B indication. Then in case of asymptomatic moderate to severe AR, along with other open heart surgery procedure, it's a class 2 indication.
Okay. So then these are all the indications for aortic valve replacement in a patient with aortic regurgitation.
So treatment of AR, surgical procedure, aortic regurgitation,
Yeah.
aortic wall, aortic wall replacement, aortic wall replacement, then aortic wall repair in patient with aortic wall prolapse, aortic wall avulsion, aortic wall perforation, then modified pental procedure, aortic regurgitation with aortopathy, surgical mortality.
Patients with aortic regurgitation with aortopathy requires a procedure which involves both the aorta and the aortic valve, which is the best procedure is modified Bendal procedure. What is Bendal procedure and what is a modified Bendal procedure? What is Bendal procedure and what is modified Bendal procedure? Anybody? What is Bendal procedure and what is modified Bendal procedure? Bendal procedure is a replacement of the aortic valve as well as
prosthetic root.
Yes, prosthetic root replacement with aortic valve replacement is a Bendal procedure. Modified Bendal procedure is what is modified Bendal procedure?
Preserving the wall. Wall preserving.
No, I couldn't follow you.
Valve is preserved, sir.
No.
Valve is preserved in that.
No. That is a different procedure. Modified Bendal procedure is that in Bendal procedure the coronaries were just chopped off from the original aorta and is reimplanted into the new aorta. But modified Bendal procedure is a button of the aortic valve is taken out along with the coronaries, and this button is stitched to the new aorta. Studies have shown that when you are just chopping off the aortic coronary artery and is refixing to the newly formed aorta, that can give rise to coronary ostial stenosis. So if you take a small amount of button of tissue, aortic tissue, original aortic tissue, and that is stitched to the new aorta, the risk of coronary stenosis is not there. So it is modified Bendal procedure that is being carried out now. Okay, yes.
Then interventional treatment.
Surgical mortality of Bendal
surgical mortality 3 to 8% depending upon the LV function and the expertise of the surgical team.
Okay.
Then interventional treatment, transcutaneous aortic wall replacement is being tried.
But it's not yet not yet very effective. Okay, right, yes.
So management, surgical, modified Bendal procedure, that is David procedure, wall sparing.
No. Modified Bendal procedure is separate. Next is David procedure. David procedure,
valve sparing aortic root replacement.
Yes. Then aortic valve is replaced. This can be done in patients with aortopathy, large aorta with aortic valve is functioning normally. There is no aortic regurgitation. You can go for David procedure. Yes.
Yakub procedure, remodeling of the aortic root.
Yes. In a patient with in Yakub procedure, the aortic root is not replaced, but it is remodeled, and aortic valve must be functionally reasonably all right. So in those patients with reasonably functioning aortic valve, and if there is a huge aortic aneurysm, and if it is remodeled, that is known as Jacob procedure. David procedure, aortic valve is spared, aortic root is replaced. Modified Bendal procedure, both aortic root as well as aortic valve both are replaced. This patient actually underwent the procedure. You can see the huge aorta. He underwent a very successful surgical procedure and he is doing extremely well. Okay, so take home message. Bicuspid aortic. Yes,
take home message. Bicuspid aortic wall disease with associated aortopathy is a complex condition and needs specialized treatment. Because of high frequency of bicuspid aortic wall disease in a general population, cardiologists should be familiar with the current recommendations for assessment, monitoring, and the treatment of this disorder.
Okay, right. I think this is all about the bicuspid aortic regurgitation, bicuspid aortic valve, aortopathy, all those things. If you have got any doubt, you can ask now. Anybody wants to clear any doubt about aortic regurgitation, aortopathy, bicuspid aortic valve, you can always ask. we have tried to cover in reasonably in good detail about the bicuspid aortic valve, aortopathy, aortic regurgitation. And if you have got still any doubt or you want to have some clarification on any hemodynamic data or any hemodynamic finding, I think it can be cleared. Some people have asked a question, I will find out. Okay, any doubts? All clear? Okay, very good. So I think we'll stop at this level. And next class, what do you need? What do you want?
Case will discuss.
Case discussion. Okay, we'll have case discussion. If one of you can bring a case, good. I will also bring some complex cases so that you can have a good exposure. I will do that. If you get a case, if you can bring a case, that will be great. Monica, are you there? Monica can always bring a case. Monica, are you there? No, she has left. So if there is if somebody has got a case, you can always bring a case, and then that case can be discussed. But I also will try to bring one. Anybody who is ready to bring a case? Anybody who would like to discuss a case? Saroj, would you like to bring a case? Do you have a case?
Sir, I will see it if I get it. Okay, sir.
Okay. If you get one, do you bring one?
Yes, sir. Yes.
Sandosh, where are you from? Sandosh?
Sir, I am from Jubilee Mission Medical College. Same Saroj Ma'am's junior. I am from Jubilee Mission Medical College, sir, Thrissur. I am Saroj Madam's junior, sir.
Yes. Oh, okay. No, Saroj is in Thrissur, or I thought she was in.
Sir, I am in Jubilee Mission only.
Jubilee Mission only. Okay. So you and what is other gentleman?
Santosh.
Yeah. Okay. Both of you are from Jubilee Mission Medical College, Thrissur.
Yes, sir. Yes, sir.
Okay. So where is anybody else who would like to, who can bring a case? Jaiswal, would you like to, will you be able to bring a case? Mukesh Jaiswal. Okay, does not matter. Anyhow, I will bring a case. So if anybody is getting a case, you please let me know so that we can discuss that case. Okay, right. Good night. Good night.
Okay.
Thank you so
much. Thank you, sir.
Thank you, sir. So from here now, I'm ending this meeting, sir.
Okay, fine. Great.
Thank you. Good night.
Good night.